Hi, this is KFG, and I am taping the online lecture for the Learning Plan Nursing Care of Patients with Alterations in the Neurological System. This particular lecture is going to focus in on the nursing care of patients with peripheral nerve and degenerative neurological disorders. First of all, we're going to look at Parkinson's disease. Parkinson's disease affects the extrapyramidal system, especially the motor structures and the basal ganglia. This part of the brain controls balance and coordination. Stimulation of the basal ganglia causes muscle tone in the body to be inhibited and allows for refined voluntary movements. And the two neurotransmitters that are involved in the action are dopamine and acetylcholine. Acetylcholine producing neurons transmit the excitatory messages throughout the basal ganglia, and the dopamine inhibits the function of these neurons to allow for control of voluntary movement. Usually there's a balance between these two neurotransmitters, but with Parkinson's disease, there's degenerative changes in the basal ganglia that lead to a decrease in dopamine, and the acetylcholine secreting neurons remain active. So there's an imbalance between the excitatory and the inhibitory neuronal activity. The excessive excitation of neurons prevents a person from controlling or initiating voluntary movements. The onset of Parkinson's disease is gradual, and it may initially only involve one side of the body. There is what they call a triad of symptoms that is characteristic of Parkinson's disease. These three symptoms are tremor, bradykinesia, and rigidity. Tremor occurs when the body is at rest and decreases when there is voluntary movement. Tremor is often called or noted as being a pill-rolling motion of the thumb against the fingers. When patients experience stress and tension, the tremor becomes more pronounced. Bradykinesia, or slow movement in speech, will produce poor body balance, a shuffling gait, and difficulty initiating movement. There's a decreased swinging of the arms when a person's walking. There may be a foot drag, producing a limp. In the earlier process, patients might lean slightly to one side, propel forward, or fall back. In the advanced stages of Parkinson's disease, there's a stiff, bent forward posture when they walk. The third symptom is rigidity, and that affects the skeletal muscles and contributes to postural changes and difficulty in movement. The postural changes affect the patient's coordination and their balance. The face of the patient looks blank or mask-like, with little or no expression. Speech becomes low in tone and slow. Enunciation becomes difficult. Drooling may occur. The patient may experience decreased tearing, constipation, incontinence, excessive perspiration, heat intolerance, and decreased sexual ability. Parkinson's disease does not affect the intellect, but some patients will develop a dementia similar to Alzheimer's. Mood disturbances can occur, and depression is a problem. Stress tends to make symptoms worse. The diagnosis is made based on the symptoms. Usually any lab tests are within normal ranges. If an MRI is done, it's done to rule out other neurological disorders. So the diagnosis is based mostly on symptoms. Here we see the dopaminergic synaptic activity that is mediated by the dopamine. Cholinergic synaptic activity is mediated by acetylcholine. A balance between the two kinds of synaptic activity produces normal motor function. If there's an excess of cholinergic activity, it will produce rigidity. And an excess of dopaminergic activity produces involuntary movements. And here we see the classic posturing for a Parkinson's disease patient. We have the rigidity and trembling of the head, the forward tilt of the trunk, reduced swinging of the arms, rigidity and trembling of the extremities, and the short shuffling gait, which leads the patient to be at high risk of falls. Treatment of Parkinson's disease usually includes drug therapy, physical therapy, and emotional support. Medications for Parkinson's disease currently involve controlling levels of dopamine. The drug therapy aims to provide dopamine to the basal ganglia and then, as a result, will reduce symptoms. Anticholinergics, dopamine agonists, and monoamine oxidase inhibitors drugs are used to control the symptoms. The MAOIs block the metabolism of dopamine, which leaves more dopamine in circulation. Deep brain stimulation is a surgical procedure used to treat many of the neurologic debilitating symptoms that are associated with Parkinson's disease. The procedure does not destroy tissue, but serves to block transmission from certain target brain areas. Usually successful treatment involves a combination of all of these therapies. There are some nutritional supplements that have shown to slow the progression of Parkinson's disease, and these include enzyme, nicotinamide, adenine dinucleotide, or NADH, coenzyme Q10, and the antioxidants of ester C and vitamin E, as well as alpha lipoic acid. Healthcare providers sometimes prescribe these supplements in addition to the traditional medications. Complications of Parkinson's disease that may develop are dysphagia and problems with immobility, as well as constipation, urinary incontinence, and insomnia. Here you see a list of drugs that are commonly used for patients with Parkinson's disease. You'll find more information on these drugs. I'm not going to get into them in specifics, but if you want to see more information on these drugs, if you go to your textbook, page 554, table 25-1 has more information. As far as nursing management goes, nursing care focuses on preventing the complications associated with Parkinson's disease and its drug therapy. It also focuses in on enhancing voluntary movement and keeping the patient safe. Constipation is a problem, so nurses encourage additional fiber in the patient's diet, as well as increasing fluids to at least 3,000 milliliters per 24 hours. Grasping coins or other objects may help decrease tremors. Walking may improve by having the patient think about imaginary lines across the pathway on which to walk. Imagining stepping over something helps prevent the freezing that the patient experiences when walking. Encourage the patient to consciously assume a correct posture. Not using a pillow when resting helps prevent flexion of the spine. Helping them to learn to sleep prone is also beneficial for posture. The physical therapist will institute an exercise program to help the patient maintain muscle function and promote mobility of his joints. Remember, the patient with Parkinson's disease will need extra time to finish tasks. A warming tray can be used to keep food hot during meals so the patient can take rest periods while eating. Falls are common and safety is a major concern. Using a cane or walker will increase stability and decrease the incidence of falls. Patients may also have leg braces or foot braces to help maintain balance. Loose carpets should be removed from the patient's residence. Also, grab bars should be installed in the shower and tub area, and a raised toilet seat should also be installed. Patients who have tremors should be cautioned against carrying hot liquids because the spills may result in burns. Patient and family teaching is very important for patients who have Parkinson's disease. Patients and families should be taught about the benefits of their medications as well as the side effects, making sure that the patients understand that they need to take their medications in order to remain more independent and decrease the symptoms of the disease. Aids for daily living using adjustable tables can help reduce arm fatigue and increase comfort by providing increased support and helping stabilize the patient's arms. Household chores such as folding laundry may provide a gentle exercise. Music can provide relaxation. Healthy eating is important as well, taking an adequate amount of time to eat comfortably and without rushing. Eating foods high in fiber and getting adequate fluids prevent constipation. To prevent drooling and salivating, the patient should sit upright when eating and close their lips and keep their chin up and try to swallow often. As far as balance, changing positions slowly. When turning around, do not pivot, but move forward and walk slowly in a circle. Use a cane with a wide rubber tip or a walker. Avoid moving quickly. Avoid moving in a backward direction. Be aware of shuffling. Stop and check your posture to make sure it's upright. And look ahead, not down. Let's take a look at a scenario. First of all, Mrs. Jones seems less animated than she has been over the past several months. Her husband tells you she has fallen 3 times since her last office visit. You notice that she seems more stooped over and her movements are jerky. The healthcare provider examines her and after a thorough history and physical, tells the couple that he thinks Mrs. Jones has Parkinson's disease. He prescribes Cinnamate for her. What can you anticipate that Mr. and Mrs. Jones will need to be taught, and what are the potential complications of Parkinson's disease? So take a moment to put this presentation on pause, and we'll just jot down a few thoughts in regard to these discussion questions. First of all, what can you anticipate that Mr. and Mrs. Jones will need to be taught? They should be taught about the schedule for taking the medications, the side effects of the medications, the need for Mrs. Jones to have exercise and stretching, how to ambulate more safely to prevent falls, how to cope with excess secretions, how to deal with dysphagia, how to maintain adequate nutrition, how to deal with depression should it occur, and how to make self-care easier. And what are the potential complications of Parkinson's disease? The potential complications of Parkinson's disease are contractures, complete immobility, constipation, and possible dementia. Okay, now let's look at multiple sclerosis, or MS. MS is a chronic inflammatory disease that causes demyelinization in the central nervous system. The most common type of MS is characterized by periods of remission and exacerbation. The cause of MS is not known, but it is believed that an environmental factor such as bacteria, virus, or a chemical, combined with a genetic predisposition for the disease, is responsible. MS is considered to be an autoimmune disease in that the immune system attacks the healthy central nervous system tissue. Myelin is a protective sheath that insulates axons and assists impulse transmission. Axon transmits electrical impulses from one neuron to the next. In patients who have MS, plaques will form along the myelin sheath, causing inflammation, and then the myelin is eroded by the inflammation and replaced with scar tissue, so that nerve impulses can no longer travel along the damaged neurons. So muscles served by these affected nerves do not receive the impulses that they need to perform in a useful manner. When the inflammation subsides, some remyelinization may occur, but is often incomplete, and the nerve transmission is no longer normal. Because the disease can affect any central nervous system tissue, symptoms are unpredictable, and they can vary from person to person. The more common symptoms of MS are motor dysfunction, which includes weakness or paralysis of limbs, trunk, and neck, or double vision caused by oculomotor weakness and spasticity of the muscles. Sensory dysfunction is also a symptom, and this includes numbness, tingling, burning, and painful sensations, patchy or total blindness or blurred vision in either one or both eyes, dizziness, ringing in the ears, and hearing loss. Problems of coordination include ataxia or unsteady gait, intention, tremors of the limbs and eyes, slurring of the speech, and dysphagia. Mental changes are usually limited to depression and cognitive problems such as impaired judgment, decreased ability to solve problems, and memory loss. Fatigue is a characteristic of MS as well and is often worsened by heat. And other problems that occur later in the disease are related to urinary and bowel incontinence and altered sexual function, loss of male and female self-esteem, physical impotence in men, and diminished sensation in women. The neuromuscular dysfunctions that are characteristic of MS are unique to each person and can vary greatly from time to time in the same person, and symptoms may actually disappear for a while. Again, there are no laboratory tests that definitely diagnose multiple sclerosis. An MRI study usually shows characteristic white matter lesions scattered throughout the spinal cord and/or the brain, which confirms the diagnosis of MS. However, the clinical signs and symptoms presented by a patient are usually characteristic enough of the disorder to allow the neurologist to make a diagnosis without even having the testing done. Diagnosis may take several years, occurring only after a second attack. As far as treatment goes, there has been a tremendous amount of success with treatment from biologic response modifier drugs such as interferon beta 1b, which has been effective for many ambulatory patients with relapsing remitting MS, and this is given by injection. Disease-modifying drugs are very expensive and are used to prevent relapses. Acute attacks are treated with intravenous steroids for 5 days, followed by oral prednisone and tapering doses. ACTH, or adrenocorticotropic hormone, may be given for its ability to suppress the immune system. Most therapeutic efforts are centered on supportive measures to maintain resistance to infection, reduce muscle spasticity, and manage specific symptoms such as double vision, speech disorders, and muscle weaknesses and fatigue. CNS stimulants may be prescribed to combat fatigue, and sometimes amantadine, otherwise known as Symmetril, is also used for fatigue. Exercise is very beneficial for patients with MS to help relieve their spasticity and improve their coordination. Again, swimming is usually an activity that provides considerable benefits because it's less fatiguing than exercising out of the water. Patients should also be provided with support and physical and psychological support as well to help develop a positive and hopeful outlook. As far as nursing management goes, the problem statements that most often are found with patients who have multiple sclerosis are fatigue due to improper transmission of neural impulses, altered physical mobility due to muscle weakness, spasticity, or paresthesia, altered self-care ability due to muscle spasticity and neuromuscular deficits, altered urinary function due to sensory motor deficits, altered sexual function due to neuromuscular deficits, potential for altered skin integrity due to immobility, altered family coping due to potential financial problems, changing roles and fluctuating physical abilities, and decreased self-esteem due to a loss of usual abilities and roles. Appropriate care for the patient with MS depends on, of course, the severity of the disease and the symptoms, so care has to be individualized for each patient. Ongoing care by an interdisciplinary team focuses in on safety, prevention of complications, assistance with physical therapy, and emotional support. Patients should not be exposed to excessive heat or hot baths, as the weakness will become worse. The importance of proper nutrition with adequate fluids and fiber in the diet should be stressed to maintain proper bowel function and decrease the likelihood of urinary tract infections. Calcium and vitamin D should be included in the diet to help prevent osteoporosis that is a result from the IV steroid treatments. Medications to decrease stomach acid and prevent ulceration from the steroids may also be administered, so medications like histamine receptor blockers or proton pump inhibitors would be started as well. Nursing should help the patient and family establish a consistent daily routine to promote optimum levels of functioning. The routine should include daily physical exercise balanced by rest periods to prevent fatigue. Patient teaching should involve education about the unpredictability of the disease and the need to prevent stress, infections, and fatigue to maintain the person's independence as long as possible. There are also referrals to be made to the National Multiple Sclerosis Society or any local support groups dealing with the same. Evaluation of care is based on whether the expected outcomes are being achieved. If they are not, of course, the plan is revised. Okay, there's 4 clinical progressions of multiple sclerosis. There's the relapsing remitting type, which is the most common type, where there are clearly defined relapses of acute worsening neurological function. There's a partial or complete recovery occurs during the remission period. Okay, another type is the primary progressive, where there's slow but almost continuous worsening with occasional plateaus and temporary minor improvements. The secondary progressive is initial period of relapsing, remitting disease, followed by a steadily worsening course. It may or may not have occasional relapses, remissions, or plateaus. And then the relapsing progressive, where the disease steadily worsens from onset, but there are clear acute relapses with or without recovery. The disease progresses between relapses. In this picture on A, you can see the picture of the healthy neuron with the axon nerve fibers covered by the myelin sheath. Then for B, again you see healthy neuron with the myelin sheath. C, you start to see the deterioration of the myelin sheath. And then D, you can see the destruction of the myelin sheath and the scarring that can occur, or in some cases the neuron or the axon actually will break in areas because of the destruction due to the inflammation. Here you see demyelinization plaque, the P that's listed on the picture at the gray and white matter junction, and adjacent partially remyelinated shadow plaques, which would be V. That's where some remyelinization has occurred. But demyelinization plaque is the section P, where the myelin sheath has been destroyed. Okay, next let's look at amyotrophic lateral sclerosis, otherwise known as Lou Gehrig's disease. It's a progressive neuromuscular disease that's characterized by the degeneration of the gray matter in the anterior horns of the spinal cord and the lower cranial nerves. After the degeneration, electrical and chemical messages generated in the brain cannot reach the muscles to activate them. Some people with ALS can survive for many years, but most experience a rapidly progressing disease that results in death within about 3 years of onset of symptoms. One of the first manifestations of ALS is weakness of the voluntary muscles, especially the distal muscles of the extremities. Some patients notice difficulty swallowing and speaking clearly because of oropharyngeal weakness. As the disease progresses, there is atrophy of the muscles. Until atrophy is complete, there may be spontaneous contractions or spasticity of the muscles and abnormal sensations such as paresthesia. The patient may also report pain, probably caused by strain on weakened muscles. Only the motor neurons are affected in ALS, so the patient remains mentally alert and does not experience any sensory impairment. Depression is relatively common as a result of the unrelenting progression of muscle weakness and muscle atrophy. Death usually results from respiratory infection and dysfunction as weakness and atrophy of the respiratory muscles impede normal respiration and mechanisms to clear bacteria and secretions from the lungs. While there is no laboratory test to confirm the diagnosis of ALS, electromyography, in a combination with muscle biopsy and a creatinine kinase, provide for a positive diagnosis. Other neuromuscular disorders such as MS, myasthenia gravis, and muscular dystrophy should be ruled out. There is no cure for ALS. Eventually, muscle paralysis renders the patient totally dependent, and the patient cannot move, swallow, speak, or ultimately breathe. The drug riluzole has been shown to slow the progression in certain patients. Eventually, impaired breathing requires a tracheostomy and mechanical ventilation. Let's go back for a little bit. Nursing management of ALS. First of all, a thorough neurological assessment should be done, and as the disease progresses, periodic assessments need to identify specific needs as the patient deteriorates. Problem statements likely to be associated with ALS are those related to difficulty with breathing, problems of immobility, dysphagia, impaired ability to communicate, pain, ineffective coping, and depression. In later stages of ALS, the patient and family need more assistance and guidance to maintain some level of independence and comfort. Rehabilitation includes obtaining equipment and devices such as walkers, wheelchairs, hospital beds, suction machines, nasogastric or gastrostomy tubes, and feeding supplies. Patients and families are likely to experience issues related to terminal illness, death, and the grieving process. The service of visiting nurses or hospice program can provide appropriate instruction and provide physical and emotional support. Now let's look at Guillain-Barré syndrome. Guillain-Barré syndrome is a relatively rare disease that affects the peripheral nervous system, especially the spinal nerves outside the spinal cord. The cause of GBS is not known, but usually follows a viral respiratory infection or gastroenteritis in adults within 10 to 21 days. There was, in 1976 and again 2009, a relationship found between the swine flu vaccine and GBS, and there have been a few cases of GBS in recipients of the meningococcal conjugate vaccine. Authorities believe that the disease is a cell-mediated immunologic response preceded by stimulation from a viral infection, trauma, surgery, HIV, or neoplasm of the lymphatic system. Pathologic changes include demyelinization, inflammation, edema, and nerve root compression. These changes bring about paresthesia, pain, and progressive ascending paralysis, autonomic nervous system dysfunction, with alterations in both sympathetic and parasympathetic systems may occur, causing orthostatic hypotension, hypertension, abnormal vagal responses, bowel and bladder dysfunction, facial flushing, and diaphoresis. When the lower brainstem becomes involved, the cranial nerves are also affected. Objective and subjective symptoms of GBS include mild sensation of numbness and tingling in the feet and hands, followed by muscle pain, tenderness, and aching, especially in the shoulder, pelvis, and thighs. There's a progressive muscle weakness, usually starting in the lower extremities and moving upward over 24 to 72 hours. It can also affect cranial nerves and facial muscles first and move downward. Symptoms peak in about 14 days. Sensory loss can occur but is not common. If respiratory function is affected, ventilatory support may be necessary. Pain is common and may be evidenced as paresthesia, muscle aches, and cramps. Pain is often worse at night when there's less distraction in the environment. Diagnosis is difficult because its signs and symptoms are similar to several other diseases. Analysis of the cerebrospinal fluid is helpful as there is usually elevated CSF protein, which peaks in 4 to 6 weeks. Electromyography and nerve conduction studies show reduced conduction velocity. Medical treatment is mainly supportive. Within the first 2 weeks, plasmapheresis, in which the patient's plasma is removed and kind of washed out to remove antibodies, helps hasten recovery in some patients. The use of IV immune globulin often hastens recovery as well. Nutritional support via tube feeding may be required because of dysphagia. The overall goals of care are to maintain adequate ventilation, control pain adequately, prevent damage from aspiration, maintain communication, maintain adequate nutritional status, and return the patient to normal function. There are 3 phases of GBS. During the acute phase, the goals are to sustain life and prevent complications related to immobility and promote rest and comfort. Respiratory problems are particularly troublesome and may require suctioning, tracheostomy, artificial ventilation, and other life support measures. Vital signs are checked frequently. Alterations in the autonomic nervous system can cause changes in blood pressure, especially hypotension. Cardiac arrhythmias can also be common, so the patient needs to be continuously monitored. Paralysis and loss of control that occurs with GBS comes on so suddenly and overwhelming that the patient can become very frightened. Because of the course of the disease, which usually extends for months, there's a very slow recovery and the patient may begin to feel hopelessness, despair, and isolation. During the static phase, it's kind of a plateau where the patient reaches 1 to 3 weeks actually after the onset of the illness. During this time, the motor loss and paresthesia no longer progresses and the patient's condition becomes stabilized. He gets no better but no worse. This phase can last from a few days to several months. During the static phase, nursing care is concentrated on preventing complications of immobility and helping the patient deal with feelings of anger, depression, and anxiety. Exercises are usually begun but limited to passive and gentle range of motion and stretching exercises. Meticulous skin care is essential because of the immobility. Monitor for thrombophlebitis. Elastic stockings and sequential compression devices are applied to the legs along with anticoagulant therapy to try and prevent thrombophlebitis. During the final rehabilitation phase, patient starts to experience a gradual recovery. If they overexert themselves, it could lead to relapse, so we need to monitor their activity. Increase activity slowly. It may take up to 2 years for maximal improvement to return to normal functioning. Then we have myasthenia gravis. Myasthenia gravis is a chronic disorder. The skeletal muscles, respiratory muscles, and muscles innervated by cranial nerves are affected. Muscle weakness can be so mild that it causes a minor inconvenience, or so severe that it can be life-threatening. Between 80 to 90% of the patients with myasthenia gravis have an autoimmune disease in which there's circulating autoantibodies directed against the acetylcholine receptors at the neuromuscular junction. This antibody reduces the number of functional receptor sites and restricts the neuron uptake of acetylcholine. As a result, the nerve impulses are not transmitted and the muscle cannot contract properly. Other types of antibodies are present in the remaining 20% of myasthenic gravis patients. There's also a suggested connection between the overgrowth of the thymus gland and MG, and associations between MG and hyperthyroidism have also been made. Symptoms of MG include double vision, difficulty chewing and swallowing, and ptosis. The voice of the patient tends to be hoarse and nasal in quality, and the voice volume decreases towards the end of a sentence. Severe muscle weakness that improves with rest is the primary symptom of the disorder. Any skeletal muscles might be involved. Intestinal, bladder, and heart muscles are not affected. The diagnosis is based mostly on history and physical exam. A tensilon test may be ordered to confirm the diagnosis. In this case, 2 divided injections of tensilon are administered. A marked increase in muscle strength is noted within 1 minute of the second injection if the patient has myasthenia gravis. The first dose is a test dose to determine whether the patient will have an adverse reaction to the medication. So atropine is kept on hand to reverse the effects of tensilon if necessary. A blood test for antibodies to acetylcholine receptors is ordered. Electrodiagnostic testing is performed to check muscle function, and a chest radiograph and chest CT will be ordered to check the thymus gland. Here you can see the ptosis that's characteristic of myasthenia gravis. They have really sleepy eyes, very weak, big weakness. Patients also experience double vision. Treatment of myasthenia gravis there's 2 main modes of therapy, and the choice depends on the severity of the disease. In milder cases, the disease may be managed by dealing with the specific symptoms rather than trying to induce a remission. Since MG patients have autoantibodies against acetylcholine receptors, plasmapheresis can be an effective treatment for patients who are in crisis. It's particularly helpful in restoring muscle function. The purpose of the plasma exchange is to remove the circulating autoantibodies from the patient's blood. It brings about clinical improvement, but it's not a cure. Anticholinesterase therapy is the primary treatment for MG. Acetylcholine must be present at the point where nerve impulses are transmitted to the muscle for sustained repetitive muscle contraction to occur. Anticholinesterase agents inactivate acetylcholinesterase, a substance that prevents accumulation of acetylcholine at the neuromuscular junction. Anticholinesterase agents temporarily increase muscle strength by allowing the acetylcholine to work. Again, though, they do not cure the problem. Two drugs that are commonly used as anticholinesterase agents are neostigmine and pyridostigmine, otherwise known as mestinon. Pyridostigmine is more commonly used because it can be taken orally. Corticosteroids and immunosuppressant drugs may also be used to suppress the immune response. Another treatment is to remove the thymus gland to decrease the antibody production. The severity of MG is assessed based on the degree of fatigue, what body parts are affected, and how severe the problem is. So nurses observe for the ptosis of the eyelid and inquire about double vision. Patients should be assessed for the knowledge of their disorder, and also the coping abilities of the patient should be assessed. Assess respiratory function, assess muscle strength of the face, swallowing, speech volume and clarity, cough and gag reflexes. Check the strength of the shoulder muscles and of the extremities. Infection, surgery, and other physical and emotional stresses can precipitate a myasthenic crisis and cause hospitalization. During the crisis, frequent monitoring is essential because the patient's ability to swallow and breathe on his own are seriously compromised. Suctioning, tracheostomy, and artificial ventilation may be necessary to maintain life until the crisis is over. Educating the patient and his family about the nature of the illness and the adverse effects of emotional upset, respiratory infections, and similar stresses is necessary. Focus care on the neurologic deficits and their effects on daily activities. Rehabilitation goals include education and support for the patient and family, so the patient remains as independent as possible. Because he can become critically ill and need medical attention immediately, a patient with MG should wear a medical alert emblem at all times that identifies him as having the disease. All should know the symptoms of overdosage of anticholinesterase medication. The symptoms of myasthenic crisis caused by underdosage of anticholinesterase agents, a precipitating illness or stress factors are equally important to know. If any of these symptoms occur, the provider must be notified immediately. Let's take a look at some case studies. Guillermo Perez had a bout of the flu about a week ago. Today he noticed he's having trouble walking. When he got home from an errand, he had trouble pulling his sweater over his head. His wife brought him to the emergency department. Which neurological problem within this chapter do you think he might have? What might be done to establish a diagnosis? What would be a top priority in his care at this time? And what further problems do you think could occur? So take a couple of minutes, put the presentation on pause, and jot down your thoughts. Okay, number 1. Which neurological problem within this chapter do you think he might have? Guillain-Barré syndrome is a likely diagnosis, and as he seems to have ascending weakness. Number 2. What might be done to establish a diagnosis? A thorough history of his previous illness and of the onset of the present complaints, along with a thorough neurological exam, will probably provide sufficient data for diagnosis. What would be a top priority in his care at this time? The top priority would be to closely assess respiration for adequacy of oxygenation. Providing for safety would be the next priority, as he's in great danger of falling. And what further problems do you think could occur? If the disorder progresses, he could become paralyzed and need intubation and mechanical ventilation. He will probably develop dysphagia, be unable to communicate, be unable to perform activities of daily living, be unable to feed himself, and experience considerable pain. Okay, let's look at the next case study. A fellow student in your clinical group confides that she has myasthenia gravis. She takes Mestinon for control of the disease. What factors could cause her symptoms to worsen, and what might happen if she forgets to take her medication before reporting for her clinical rotation? Take a moment and put this presentation on pause and jot down some answers for these two questions. Okay, what factors could cause her symptoms to worsen? The symptoms could worsen with any greatly increased stress or emotional upset, a respiratory infection, or severe trauma. What might happen if she forgets to take her medication before reporting for her clinical rotation? If she forgets to take her medication before coming to the clinical rotation, she may begin to experience muscle weakness. She should watch for diplopia, ptosis, extreme fatigue, dysphagia, and weak speaking voice. If a man comes to the clinic complaining of difficulty enunciating, having tingling and prickling in the extremities, and having increased difficulty walking, the diagnostic testing has determined that he has ALS. What is the focus of interdisciplinary care for this patient, and what is the prognosis for this patient? Again, put this presentation on pause and jot down your answers for these two questions. First of all, what is the focus of the interdisciplinary care? The focus of interdisciplinary care is to prevent complications of immobility, support respiration, teach measures to deal with dysphagia, provide a means of communication as the condition progresses, provide adequate nutrition, provide assistive devices, medicate for pain, provide therapy for depression, and support coping mechanisms. What is the prognosis for the patient? The prognosis for ALS is grim. The patient will progressively lose more and more muscle control. Muscles will atrophy, swallowing and speaking will become difficult or impossible. Pain becomes a problem with spasticity and paresthesia, and because the patient is mentally alert and aware of what is happening, depression sets in. Eventually, mechanical ventilation is necessary. Most patients die within 3 years of diagnosis.